Hello and welcome to the concluding session of the third annual Completed Life Fall Conference. Today, day 3. My name is Sarah Kiskadden-Bechtel, Program Director for the Completed Life Initiative, and I will be your host today for this morning's session of Greetings of Palliative Sedation. Today, our esteemed speakers will examine palliative sedation as a means of alleviating suffering at the end of life, and will refer to a physician's use of opioid and other medications to gradually modulate a patient's experience of pain and to reduce consciousness until death. Palliative sedation exists on a continuum in a relative gray area between self-administered and physician-administered death, and is therefore poorly defined. William Husel, recently acquitted, was tried for first-degree murder after being accused of administering an extremely high dose of fentanyl to 14 critically ill patients. The prosecution wanted the jury to find that Husel must have intended to hasten and therefore cause these patient deaths. This session will explore how the principle of the double effect becomes central to clinical considerations of palliative sedation, and how these might influence bioethical decision-making moving forward. For this concluding session, I have the honor of welcoming back David N. Hoffman and welcoming for the first time Dr. Robert Horowitz to the Completed Life stage. David N. Hoffman is a healthcare lawyer and clinical ethicist in New York, where he is assistant professor in bioethics and full-time core faculty member of the Columbia University Master's Program in Bioethics. He also teaches in the areas of law, medicine, and ethics at the Albert Einstein College of Medicine, where he holds an appointment as a clinical assistant professor. He also serves as the Chief Compliance Officer for Carthage Area Hospital, is admitted to practice in New York State and federal Southern and Eastern District Courts, and is an esteemed member of the Completed Life Initiative's Steering Committee. Dr. Rob Horowitz is the Georgia and Thomas Gosnell Distinguished Professor in Palliative Care, board certified in internal medicine, pediatrics, and hospice and palliative care medicine. Dr. Horowitz is a physician, educator, and since 2015, leader of the URMC, University of Rochester Medical Center, Division of Palliative Care at Strong Memorial Hospital. Dr. Horowitz also founded and served as medical director of Rochester's Adult Cystic Fibrosis Program from 1999 until 2015, and he worked for 14 years as a rural emergency physician. In addition to his clinical duties, Dr. Horowitz teaches palliative care and communication skills to medical and other health career students, residents, and fellows at the University of Rochester School of Medical and Dentistry. Before we begin, please be aware that you may input your questions into the Q&A feature located on the lower right-hand corner of your screen. Please feel free to submit your questions throughout today's event, and later on we will turn to your questions for an interactive Q&A with our esteemed panelists. If you'd like assistance with closed captioning, you may toggle on the box located in the lower left-hand corner of your screen, and this will provide captioning for the spoken words of today's event. Finally, the recording of today's event will be published after the conference concludes. Welcome, Rob and David. Without further ado, let's begin.
Thank you so much, Sarah, and welcome, Rob, and welcome to the CLE community to our discussion today. This is really the most conceptually, clinically, and ethically challenging part of what we do in clinical bioethics every day. So I am just thrilled to be joined by Rob to dig through the connections between the medical and the ethical. So Rob, welcome and thank you. Let's start here. I'm curious to know, and for our community to know, when did you first encounter the notion of palliative sedation, and how did you feel about it?
That's a great question, David. Yeah, and thanks, Sarah, and everybody else. Boy, good tough starting question. You know, I encountered it before I called it palliative sedation. The term is relatively new to the clinical practice. And I would tell you, looking back at, I witnessed it during training 30 some years ago in ICUs when patients were sick, where their outcome appeared to be futile, at least in some people's eyes, and where, and I would say on occasion, I witnessed an attending physician offering medication to ease discomfort with a sort of, and I can't tell you, my sense is never explicitly stated intention of easing that suffering by giving a dose of medication that caused unconsciousness, if not cessation of breathing. So I think I witnessed it in the sort of the hidden curriculum, the not stated space, more than once during training. Had mixed feelings about it, recognizing early on, you know, I think our paths to the work we choose are interesting. I'd always had a sensitivity to caring for people who are suffering. And so there was some relief in seeing someone willing, I dare say brave enough to do this, and some anxiety about the potential implications, the potential perception of recklessness involved. So yeah, I think probably very early in my training is the first time I saw what now I might look back and call covert palliative sedation.
That's so interesting and kind of exactly what I was curious about, because you are now quite literally a professor and a clinician of palliative care.
Yeah.
And yet, when you and I started our training in healthcare, you as a physician, me as a lawyer, this didn't have a name. And I distinctly remember my first encounter with palliative sedation, which was quite overt and explicit and not in the context of end of life care.
Mm.
And that's a theme that I want to return to continually throughout our talk today, because I think it's really important for our CLE community and the entire medical and ethical community to understand that there are so many dimensions to this discussion of palliative sedation, and how important it is to distinguish what we describe as palliative sedation from the notion of pain management and the whole issue of the double effect. Many people confuse those ideas, and in a way that I think does a disservice to patients. My first encounter with palliative sedation was decidedly temporary. It was a patient who came to one of my hospitals with a seizure disorder, and they could not, with any of the standard interventions, manage the seizures. And the doctor in the ICU sedated him. And I remember thinking, oh my heavens, what a great idea. Why have I not heard of this as an intervention before? And I have, in the ensuing years, paid very close attention to the circumstances where sedation is indicated either totally or partially, and either temporarily or as a definitive intervention, the kind of thing that you described. So, Rob, describe for us the journey from that first moment when you realized that this was going on and people didn't really acknowledge it, to where we are today in your practice. What has that been like for you as a physician?
Yeah, it's been a long while, 30 years, you know, a blink of an eye geologically, but a long while. And along the way, I had the good fortune of being here in Rochester throughout my training, and had luminaries, mentors like Tim Quill, who you know well, to lead the way and open up conversations about the covert actions of clinicians, well-meaning, compassionate folks who had no recourse, but at times, or at least so it appeared, to secretly provide medications to patients who were suffering refractory to conventional treatments. And he opened the conversation, as you know, back in 1990-ish.
96.
Um,
Yep.
where he made sort of a public confession about doing this, and he was not alone in doing it, but was brave in bringing this to the conversation. And over the ensuing 20 some years, I'm happy to say palliative care has grown. Recognition, even without the specialty of palliative care, because this is not to market palliative care, the specialty, but palliative care, the stuff, which I don't feel like we, the specialty, own in any way, honestly. To publicize the necessity of considering refractory suffering in folks throughout their life, not just at end of life, and how to, without being secretive, to be open, honest, conspicuously so, even about best practice to help meet that unmet need. So, so over the years, that's meant many things. And we're at a place now, I can fill in some of the blanks if that's important, but we're at a place now where you and I are talking here publicly about the range of ethical and legally supportable ways of addressing that kind of suffering. We have here policies. I've become the inheritor of much of what Tim was doing before me, and we have written policies around what in the title refers to the gradients. I think there's some definitional challenges here we ought to address, but of treating that kind of severe suffering, whether it be catastrophic or gradual and anticipated. So this is part of our nomenclature, it's part of our practice, it's part of our policy approach and guideline approach, which we're talking about. It's not always straightforward, it's controversial, it's provocative, and that's what makes these conversations fun.
And really so important. So we're definitely going to get to all of those definitions, because I think it is probably one of the greatest values we can provide to the CLE community and our audience today. But I want to pick up on something you just said as a more foundational point. You said that people early on were doing it secretively. Why do you think that was? What was the prevailing attitude that you encountered among your colleagues that led them to think, oh, this is not something we shouldn't say the quiet part out loud?
Yeah.
What was that about?
Well, I think the history of medicine is long and complicated, and not confined to Western medicine as we talk about it, of course. But clearly this was a time, I came up in medical training in the late 80s into the 90s and such, when technological advancements were creating the impression, in one of my colleagues' words, not mine, that our goal was to eradicate death from all causes. And this unachievable, aspirational, maybe crazy idea that we could overcome mortality in some way. And it is clear that amazing technologies and advances in medicine yielded incredible gains in treatment of illnesses that at one time were perceived as death sentences, AIDS being one of them, progressing cancers another one. And we've learned a lot along the way in that space where technology was doing so much. The evidence was also mounting that those who were suffering greatly with progressing illness were not getting the kind of due attention they needed. And in previous decades, certainly centuries, they were getting the attention they needed. Death was understood to be an inevitability, and clinicians were allowed in ways, sometimes stated, sometimes not, to help ease that passing from being alive to being dead. In the 90s, not so much. And there was, I think, and there's probably some good sociologic literature about this, but the general sense was death is a failure, and we need to account for that. And there wasn't a lot of open conversation around how to meet the need of those who were suffering, unnecessarily in their dying. There wasn't license. Tim Quill hadn't spoken out, and others as well, about this. It hadn't become part of the national discourse or the discourse in medical school, which it is now. My class, my second year medical school class, is waiting for me on Monday to talk about serious illness conversations and this very thing. It's just part of the curriculum, and it wasn't then. So, so what do you do if you're met with a patient and your commitment is to help ease suffering, compassionately, and there's no guideline to support this, and you suspect that you're doing what you think is the right thing is potentially seen by others as unethical or illegal? Well, many people chose to do what they perceived was the right thing, and to prescribe secretively medication, or to give medications in the ICU, for example, as I described, that help meet that need without much talk. So again, I was a witness to this a few times without much conversation about what went on, but a sort of wink, wink, I would say, and I don't mean that in any crass way, recognition of exactly what was going on.
Which is fascinating to those of us who haven't been through medical education, and in particular to me as a lawyer, because of course, when we talk about sedation, that's never been illegal. There's never been any legal prohibition on making someone not aware of the pain they're experiencing, right? This is what happens every time any of us goes to the dentist. And it leads us right into the topic that you referenced a moment ago, which is these definitions. So let's just dive right in. We have means of sedation. We have means of providing analgesia, the relief of pain. And it seems from your comments that when you started your training back in the 80s, maybe a lot of doctors weren't being told by capable lawyers, hospital lawyers, that one legally has nothing to do with the other. So can you, for starters, describe to our largely lay or non-medical audience how you manage relief of pain, so fentanyl, morphine, and introduction of unconsciousness or minimal consciousness as two tools that you have available to you to manage a patient's experience, either at the end of life or prior to the end of life?
Yeah, they're I'm not so sure they're discrete, and even within the different the languaging around palliative sedation, I think there's some. First of all, there's not broad consensus about languaging. There's disagreement about languaging, and there's use of language in this realm that I think sometimes fails in overlumping and in oversplitting. And I'll declare what I mean in a moment. So if my task, if my mandate for a patient who's suffering from just to give this a picture, somebody with cancer-related pain, cancer-related chest pain, lung cancer in the bones, and it hurts. It hurts to breathe, it hurts to move. My job, among others, is to ensure my patient and family understand what's going on as best they're capable, and that we explore their values in the context of what's going on. And this may vary depending on where they are in their life. It may vary depending on their background, their cultural background, their racial background, their religious background, their age, a whole host of factors. Once we have some clarity about their contextual values, given what's going on, we can then define a treatment plan for every aspect of what's going on, treating the cancer or not, how to do it, how to treat the pain. I want to unlink pain and opioids. Pain can often be treated without opioids, and often opioids are a very valuable tool, a gold standard for treating pain, but not useful for all pains. and not appropriate for some pains, not necessary. And sometimes even a lot of opioid doesn't help ease the symptom. But using it among other medications for a person with, let's say, cancer-associated chest pain in the setting of lung cancer, depending on my conversation with my patient, David, imagining you're my patient, I'm going to have a discussion with you about what's possible. We're going to talk about expectations. And that's going to vary depending on where you are in your life. If this is a brand new diagnosis and you're up and well and engaged in your life, or if you're dwindling and sicker and frailer, or if you're in bed in your last hours or days, the conversation is going to have a different flavor. And probably, as we know, however you anticipate it from here, your values will change contextually. You'll have a different wish for how we might get to that pain and how much you're willing, if I'm using opioids, to tolerate ease of pain in trade-off with lessening of consciousness, for example, right? So, and I can get more specific, but I would say broadly in your question about how to treat symptoms, you and I are going to come up with I don't know, I spend a lot of my days doing something like this and talk about guardrails, the least I can do, the most I can do. And if you were to say to me, just put me to sleep, well, that's not going to be on our first date. That's not our first discussion. But I'm going to talk about what we might achieve with opioids and other things. You'll talk about where the balance lands in terms of relieving the pain and maintaining clarity or not. And we'll define a plan and have ongoing conversations about how to get there as we adjust that as things unfold. Yeah.
You have touched upon exactly the issue I wanted to bring forward, which is the relationship between relief of pain and suffering on the one hand, and monitoring or modulating both levels of consciousness, that is awareness, and levels of respiratory depression, right? Those are what we want to the maximum extent possible, relieve all pain and as much of the existential suffering as we can with the tools available to us, some of which are drugs, some of which are talk therapy, and lots of other things. On the other hand, managing both in terms of the medical implications of the intervention and in terms of the patient's preferences and values, whether they're going to, on the one hand, remain conscious, remain responsive and able to engage in conversation with clinicians and loved ones, and whether the medication that you administer is going to depress their respiratory drive in such a way that in the first instance, it might contribute to depressing their level of responsiveness, but might also contribute to depressing their ability to breathe, which is the sort of nexus for the double effect, which we'll talk about in a little while. But right now, just talk a little bit about how you communicate with patients, and use me as the patient, because I think this is a useful role play about those trade-offs.
Yeah.
Pain and suffering on the one hand, respiratory drive and consciousness on the other.
Yeah, right. And I appreciate your naming pain and existential suffering. These are probably overlapping in some ways, but these are discrete in some ways as well. And we may use very different tools for those. So pain, just complicated experience pain. So if we're talking about pain coming from a somatic, a body source, cancer in the bone that hurts. It doesn't always hurt, but it can hurt. It can hurt terribly. There's pain, and and I want to be careful about trivializing some of the language here, but there's pain and there's suffering. And there are people who can have pain, and while none of us can know the other's pain, this is not something I can, like with a blood pressure cuff measure. You can describe it in any number of ways. Some people seem to be okay, can tolerate certain kinds of pains in ways that other people are suffering. So the issue is, in some ways, what is the experience of pain? What does it feel like in a somatic way? How can you describe it? There's also the impact of the pain on on your life experience. There is a component of pain that has to do with emotion. There's a component of
Indeed.
pain that has to do with meaning, right, or thinking. Sometimes cognitive behavioral therapy, believe it or not, is useful for pain, because the pain has meaning that is sometimes causes suffering,
Mm-hmm.
that discussing the meaning of the pain can actually change things. So for example, somebody with chest pain that's severe might reasonably worry about their heart and their life, or somebody with wrist pain, which can be miserable, by the way, severe wrist pain, is not typically going to be thinking this is life-threatening.
Mm-hmm.
That can be valuable. It can make the experience different, is all. I don't want to grade a hierarchy of suffering here per se, but that's
Yeah.
relevant. So all the different experience of pain is important to us to address here. To the extent opioids might be helpful here, I do want to be aware that opioids, when I'm offering you morphine, David, for your cancer-associated pain, my ideal is that it diminishes the transmission of the pain signal to your brain, because all pain actually is in our heads. This is where you experience it. I want to turn down the pain amplifier so it doesn't hurt as much.
Mm-hmm.
I am not looking in that case for you to have the collateral impact of the opioid, which might be pleasure, it might be nausea, it might be constipation, it might be slowing of your breathing if I give you a substantial enough dose. All of these are sort of collateral effects of the opioids, because I can't target just that pain spot unless I do it procedurally. If I give you systemic opioids, something by
Right.
mouth, something by vein, it's going everywhere in your body. And it can have beneficial, if the euphoria that you might experience, I don't know if you do, with morphine obtains, and the downsides, collateral risks, which could be slowing of your breathing, which you might at some point in your life see as desirable, right? So we take that all into account.
Mm-hmm.
And I'm going to have a conversation with you about, given where you are in your life right now and in your cancer treatment, and depending upon your understanding of your prognosis, your lifespan, cognitive, functional, symptom prognosis, what matters to you now? And if we have to, here's another thing I do with my hands all day long. Where's that balance of easing the pain, but losing some of your clarity, probably at higher doses of opioids, or maintaining clarity at all costs and hurting a bit more, maybe even a lot more? You and I will negotiate that. And you'll tell me where on that, if this is the blunt instrument tool that I'm going to be using, and opioids are,
Right.
we'll come up with some agreement where to start.
So interesting. As you were talking, in addition to balancing and setting guardrails, you were pointing to either your clavicle or your scapula as the source of pain. Interesting, because my mother-in-law had osteosarcoma, and that informs a lot of my understanding of what it actually is like to have bone pain, which is terrible.
Yeah.
I'd like to reframe the discussion just for a moment to the thumb. So I come from a family of carpenters, and I've whacked my thumb with a hammer more times than I care to remember. And for years, sometimes I've had a black thumb. My grandfather, who my son is named after, had a black thumb the entire time I knew him.
Yeah.
So that's a particular kind of pain. And then I want to offer you another example. I'm an avid rock climber, and when you rock climb, you're shoving your hands into cracks and you're bending your skeleton in ways that it wasn't really designed for, and that causes pain, but you want that to the extent that it is part of the package of climbing, and that's not only tolerable, it sort of goes with the territory. So let's use those two kinds of notions of pain to discuss what you are telling your patients you can do for them, using that balancing of relief of pain, that physical pain. So let's focus on the whacking your thumb with a hammer, against losing consciousness or otherwise losing lucidity and the ability to intellectually engage.
Well, it probably goes without saying, but better say it. You are not going to get a palliative sedating dose of oxycodone for your thumb or for your body after rock climbing and taking a fall. I know that space as well. So I think for the audience, it's really important to know, in most cases of serious illness, palliative sedation is not part of the conversation because it doesn't need to be, because we can pretty well treat most episodes of pain adequately enough that people can be less uncomfortable or even quite comfortable through their natural dying, through the dying time, whatever that might look like. So using palliative sedating doses of opioids or other things, and I want to make an important distinction next talk, because rarely do we actually use opioids for palliative sedation, actually. That's a different space. We're using that to target, to the extent this blunt instrument, and I use that term a lot, opioids can target pain and shortness of breath. So, but if we're going to move this then from a hammer-induced injury of your thumb to metastatic cancer pain in your thumb and your whole body that is preventing you from sitting, eating, making love, moving about, engaging in meaningful conversation, the pain is interfering with your engagement in life, that is an urgency that we need to address. And you will discuss, I hope, with me, one of your clinicians, what matters to you given this. And you, who I know, I don't know you well, David, but I know you value what's going on up in here. I wonder at this point right now, today, if that were what you were facing, how much of this clarity you'd be willing to sacrifice, to surrender, in order to feel less of that pain that is interfering with your capacity maybe to talk with me, at least with a smile on your face, or sleep well or eat. That's the nature of the conversation. I will not, in most cases, except in severe advanced, ideally, and I'm saying ideally to make the conversation easier, imminent end of life, offer opioid treatment for pain to the point of being asleep. That is a relative rarity and relatively rarely needed. But this is part of the conversation.
And absolutely, this is what's going on at bedsides around the world when conversations occur with clinicians and with ethics consultants about what are we able to do, and of what we are able to do, what do you want, right? So I, for example, just recently had a total hip replacement. And when I was sort of living with the discomfort, I won't even call it pain, but the discomfort and the loss of function, I couldn't tie my shoes. I called a friend who happens to be a doctor, and I said to him, when will I know it's time? And he said, and this friend had had 2 hip replacements in addition to being a doctor, so had experience on both ends of the spectrum. He said, David, you'll know. And I said, I know, but how will I know? What is it? What's the measure? And he said, no, David, you'll know. And about 2 months later, I was reaching over to tie my shoes and I couldn't tie my shoes. And I said, enough of this. I'm 62. I don't want to be living unable to tie my own shoes anymore. And I went and got a hip replacement. That's in the context of needing remediation of pain, discomfort, loss of function in a non-end-of-life situation.
Yeah.
When we talk about palliative sedation, as you said, we are more often, when we talk about palliative sedation to unconsciousness and permanent palliative sedation to unconsciousness, we're almost by definition talking about an end-of-life situation. Our classic definition of terminal illness, 6 months or less to live, or unbearable suffering.
Right.
So,
Yes. And just to add to that, then, one of your colleagues here at this hospital was called in a situation that I was tending to, somebody with a non-life-threatening illness and a severe pain condition. Pain is awful, and it was impairing their life. But it was interesting. This person's asked, he was hospitalized for a complication of his kidney disease, needed to be in the hospital, needed IV medications, and his wish was to get IV pain medication appropriate to the pain. I mean, this was a
Right.
pain condition that if we were to make it tolerable for him would require very, very large doses of opioids, and they caused him to be sedated. We could tolerate that to the point of sedation. His ask was enough pain medication for this condition that he might stop breathing, in which case he wanted us to put him on a ventilator. And there was a line there. He was not imminently dying. He did not want to ease the pain even at the cost of living, which might happen at end of life.
Right.
And that's a space within which palliative sedation or acceleration of opioids for pain management is a different deal than in the space we're talking about, I think, in large measure. So in that space, yeah, please go. Where should we go with that? What would be useful for us to reflect on in that space of serious illness, presumably relatively short lifespan, weeks, months, maybe?
Right.
Yeah.
So to answer your question, if I were your patient, given my values and priorities, I would tell you, medicate me enough so that the pain is tolerable, is sort of in the background, something analogous to the pain that I experience when I'm rock climbing, where I'm intentionally inflicting that pain on myself for a greater purpose, and maybe at the higher end of that, but keep me as conscious and engaged and intellectually functioning as humanly possible. And I'll let you know when the pain means that you're keeping me too conscious. And I think that's exactly the kind of conversation that has to go on, but it has to go on in the context of the parameters that I mentioned a moment ago that I want to go deeper on, which
Right.
is this notion of permanent versus temporary, partial versus total. So when you're talking about a patient who is at the end of life, either fitting our classical definition of terminal or maybe something just shy of that, but clearly where we're going to be less concerned about the addiction risk and more concerned about the respiratory depression risk. How do you have that conversation with a patient?
Yeah. So if I can take you off of the rock and have you, can I, and seriously, this becomes personal, but can I put you in the hospice bed?
Oh, of course, absolutely.
Okay. So imagining a progressing illness, imagining your confrontation with the knowledge that the oncologist just shared with you and your people, whoever they may be, that David, there is no further disease-directed treatment that's likely to enhance your function, your well-being, and or prolong your life. And our best guess is, given the progression of this disease, your lifespan is now measured in weeks.
Mm-hmm.
Okay, if that's your imagining, and you are, as your mother-in-law was, and
Yep.
again, I know this is getting personal, so I want to be careful
That's
about
okay.
that, but riddled with cancer and pain
Yep.
that is interfering with this kind of conversation, with engagement with those you love, with sleeping. It's too much.
Mm-hmm.
And we can't put a number to that. I had a colleague recently say, we're always trying to keep pain under a 4 out of 10. I don't know. What's your 4? But if it's interfering with your life in a meaningful way right now,
Right.
let's talk about that. What can we do with that? And depending on your degree of engagement, your capacity to eat and drink, your joy and pleasure in doing so, your quality of life right now, how you anticipate it will be over time, we'll talk about that, not once, but we'll talk about it today as we're getting to know one another.
Mm-hmm.
And I'm going to check in with you if you're on my palliative care unit because you need IV medicines. I'm going to talk with you day by day, hour by hour if we need to. If I'm seeing you outpatient, we may have phone call. We'll see. We'll follow up as we need as things change. And the conversation will be something like, how do you define right now, given what you know, what you're experiencing, what would make this better or better enough?
Mm-hmm.
What is your functional goal?
Right.
How would you like this pain to be? What would you like to be able to engage in?
And your transition from my rock climbing pain to my cancer pain is, ethically speaking, exactly the point. Because again, for me, N of one, if I am nearing the end of my life, 6 months plus or minus doesn't so much matter to me. But if that's where I'm headed, then I don't want you to be keeping my pain just tolerable to eke out a few more days or weeks. I'd rather talk to you as my palliative care physician about, okay, keep me comfortable so that I can say my goodbyes and then keep me completely comfortable. And completely comfortable, again, goes to this now permanent, not temporary, and now not so partial, but moving toward total palliative sedation, perhaps to unconsciousness, not as the goal. So I wouldn't be asking you, can you just make me unconscious? I don't want to have to even be aware of this. Open question whether unconscious patients are aware or not, and that's a tough call. But I'd be saying to you, make it as total as it needs to be so that I'm not suffering at all. And if that means I'm going to die days, weeks, or even months sooner than I might otherwise, I'm fine with that.
Okay. So that's an important conversation, and I'm gonna ask what you mean by totally comfortable. That I think any language like that needs to be dissected a bit further. You've just shared a little bit about what I think you mean, but I really want to know explicitly. And what I'll do then in this circumstance is have a conversation with you and those you wish to include in the conversation. This is often done with partner, children, parents, whoever you decide, because they're going to be the survivors of your experience. They matter, some probably to you. You may want them to participate in the conversation. We'll see. And we'll talk about how to get there stepwise. And that might be liberalizing the use of the opioid. I am not particularly worried in this case, as you're developing some tolerance to the opioid, that we're going to cause you to die because of respiratory suppression. The brainstem very quickly adapts, the body very quickly adapts to escalating doses of opioids, as it can adapt to and develop tolerance to the pain relieving effect of the opioid. Consciousness may be altered, and you'll let me know if this is acceptable or not. And we can increase that and address other aspects of your pain and experience, because it's not just physical pain we're talking about here, with other treatments, presence, conversation, clergy, whole host of interventions that we want to think about, right? But again, focusing on the pain. And I can, in this place, with your license, be quite generous in dosing the medications to achieve proportionate with your wishes. Now,
I love the expression "quite generous."
well, and I really mean that, because I have a guardrail. So you could say whatever it takes, Rob, wink, wink, and I'll ask you, what do you mean by that, David? Just end me. We're kinder to our dogs. Give me that big bolus of fentanyl, like that guy in Ohio did to all of his patients. Bless him. He did a beautiful thing. Well, I'll say, well, hold on a minute. Actually, that's outside the guardrail.
Right.
I'm not going to do that. So we can be quite generous, but it's not without a limit. There are breaks in the system at this point. Fair?
Absolutely. And so you have brought us to the next place we need to explore, which is the double effect. And then from our conceptual discussion of the double effect, we'll talk about William Husel, the doctor in Ohio, because for better or for worse, the fact that they decided to put him on trial for murder, not even criminally negligent homicide, little legal footnote we can get to, and that he was acquitted, really informs what doctors should think about where the guardrails are.
Yeah.
So let's start with the notion of the double effect, because that was central to the original lawsuit that was brought, that Tim was involved in, Tim Quill. And so we need to pin down the medicine, the ethics, and then we can deal with the practicality.
And actually, David, I want to introduce, because I think it's important. We're about halfway through our time, and we haven't yet talked about palliative sedation, what it really looks like on the ground, because
Yep.
this is not palliative sedation.
Exactly.
And what Husel did is not palliative sedation
Right.
either. So let's make
Yep.
sure we give some time for that. And I'll just put in a buzz for this. The notion of palliative sedation is using sedatives. I'm not talking opioids, but I'm talking sedatives like benzodiazepines, Valium, lorazepam, Ativan, that class of medicines, and or barbiturates, and or propofol, other sedatives to help ease the suffering that we are not satisfactorily relieving with conventional medicines. So like for you, if the opioids are not satisfactorily relieving your pain, even at the point, you're appearing sleepy, unconscious, but miserable and wincing, this is a place where palliative sedation using a sedative, where
Yep.
our standard treatments aren't working. That's what, in a way, this is about. We haven't gone there yet. So,
Well, and we're going to, because
That
that was my point at the
great.
outset
Glad.
about the difference between sedation and analgesia.
Glad. Okay.
And
Good.
I
Good.
purposely want to deal with the pain part because that's where people's minds go.
Yeah.
Our discussion in a moment of the
Great.
sedation part will be the counterpoint.
Great.
So talk to me about this notion
Right.
of the guardrails and how the double effect impacts your day-to-day practice.
Right. So, the double effect, meaning in very simple terms, and boy, you've got a much more eloquent way of describing that, I know from your background. But in my mind, what that means is it's all about intention and about being explicit. So I am intentional in my easing your pain, with the explicit intention not to make you die by the medicine I give you. And I do share this with every patient I talk with, because I think sometimes they think, oh, Horowitz I know what you're doing. You're starting the drip. We know where that leads. Well, no, where it leads, I hope, is to less pain, less suffering, and whatever degree of clarity you can have. And I'm talking generous, big doses of opioids. Somebody who's opioid naive, it may not take a lot. Somebody who's had a lot of opioids, it might take a lot. We may not even be able to get there with a massive dose, like those described in the Husel case. The brainstem can be overwhelmed when people die of a clinician-delivered dose of medicine because of shutting down the brainstem, or out in their home with a IV dose of fentanyl or heroin or Vicodin. The death is usually because it stops the brain stem's awareness of breathing. Breathing stops, people fall asleep and they die by not breathing. They don't experience suffocation.
You in effect forget to breathe.
Yeah, and don't know they're not.
Right.
Unconsciousness ensues before the breathing stops in most cases. Or a different degree of consciousness, probably. So in the medical space, though, the Husel case is different than what we're talking about gradually increasing doses proportionate with your wishes as things change. That's in a particular case where somebody is on life support on a ventilator. And this is a different, just to be clear, this is a different policy here. It's different guidelines than palliative sedation or pain management. This is stopping life-sustaining treatment, artificial life support, with the recognition that removing a breathing tube in someone who needs it to keep living will cause suffocation. And I will not allow my patient to suffocate to death. So in a case in which we know they can't breathe without the tube, and we have some good pre-removal tests for that, when we know they won't be able to breathe without the tube, we know they're going to not breathe enough to survive. We know that if we don't treat them with medicines, they will suffer through that agony for minutes to hours or longer. That's a case where using medicines, opioids and benzodiazepines, typically mostly in combination, in anticipation of removing the tube until they're comfortable, and then in reaction to how they respond, will make that dying a peaceful one, right?
So this is the notion of oxygen starvation, right? You don't want patients to experience that hunger, that need for oxygen.
Well, right. And it's actually, it's not even the oxygen, it's the movement of the air.
Mhm.
It's the trying to breathe through a straw. Your oxygen level is going to be fine for quite some time, but try to breathe through a straw and then a narrower straw and then pinch it. And imagine how long you could do that. And imagine there's no out.
Mhm.
You will eventually starve for air. And yes, ultimately oxygen, carbon dioxide will go up. Awful, awful way to go.
Mhm.
So yeah, so we can treat that if
Mhm.
we know that that's the medical situation that's forthcoming.
So what we're talking about here in ethical terms is the difference between first order objectives and second order impacts, right? When you give any medication, whether it's fentanyl or morphine or any of the sedatives, you know that you're doing it to achieve one effect. That's your first order intended effect. You know that it can, and in some cases will produce a second order effect. And this is where we run into one of those homonym problems, right?
Mhm.
Because the word intend or intent has to mean two different things. You're intending to administer the drug, so that's one kind of intent. You know that it will produce the first order effect. That's the one that you're shooting for. You also know that it will at some point produce the second order effect. So by intending to administer the medication, you're aware that there's a cause-effect relationship between what you're doing and the second order effect.
Mhm.
That doesn't mean that you intended to end the person's life, or even that you intended to introduce a cessation of respiration.
Mhm.
And to the extent that you are trying to achieve your first order effect and minimizing, but not making an effort to eliminate the second order effect, that's the ethical definition of the double effect.
Right.
And everyone doing this work needs to take that to heart.
Right. And I'd go just even a little bit further is that second order effect is not a foregone conclusion. That a lot of people who are extubated, are simply not going to breathe. The medication is not going to make them breathe less than nothing. They're going to breathe not at all. Somebody with ALS, a neuromuscular disease, somebody who's got a severe stroke who is not breathing, somebody who can't move air, the likelihood of their dying because of what's going on, the natural death will ensue when that tube comes out within minutes, likely in either case. And
Right.
so the opioid actually in those circumstances, and this is going to be impossible to prove in many cases, is
Mhm.
probably not going to accelerate their dying. And if it does, it's likely just in a short order. Now there are cases in which it's not clear. There may be some breathing, and it may be difficult breathing. And this is a case in which I enter into a discussion with you, David, and I say to you or about your loved one whom you're speaking for as surrogate, um, my commitment, here's a place where the guardrail, I will not allow your dad to struggle. I won't do it. And you can say, I don't like opioids. I'm not, we're against them. My brother
Right.
died of an opioid. I'm going to say, I will not allow that. I will give at least enough medicine that he is appearing, our best surrogate for how he's doing, appearing comfortable, not gasping.
Right.
And if your leaning is, I'd rather you just put him down, I have license to lean, a little bit more towards that generous end. And I don't use that word to trivialize it, but not with the intention of stopping his breathing.
Right. And that is where intention is so important, both ethically and legally in your work.
Yeah.
And we ought to footnote in this discussion the notion of medical humility, because, as you mentioned a moment ago, we're not always certain that a particular effect will occur. And we have our reminder in Karen Ann Quinlan, right?
And that whole legal fight in New Jersey in the 70s, specifically because the doctors were so convinced, so confident that turning off the ventilator would be the equivalent of killing her. And it turned out that they were mistaken, right?
Right.
So that needs to be part of our ethical discussion as well.
Yes. Right. So somebody in that condition, so if you stopped breathing on the basis of a pneumonia that has resolved, even if you suffered severe brain damage, but your brainstem is working and moving enough air, you might well live when we stop that tube. And we're going to have a discussion beforehand. And this is not a case in which I'm going to be providing those big doses of opiates. I'm going to give enough to make sure you look comfortable. We'll take out the tube, and you may have the misfortune, and it could be a tragic one, of living on in a way you never would have wanted to, breathing autonomously. And my job is not then to overcome that with medicine that stops your breathing, even if that would be your wish or your family's.
Yeah, so let's turn for a moment to the Husel case, because I think it's very illustrative of this difficulty with the notion of intent. We're blessed that the trial is over because we now have access to a lot of information that was not publicly available while the case was being developed and tried. And there was a remarkable conversation that was reported between the two doctors who served as expert witnesses on both sides of the case. And I found a statement by the physician who was the expert for the prosecution. And of course, the prosecution lost, if you want to look at it from a technically legal way. But what the doctor, Dr. Eli, said, I found fascinating, and let me share it with our audience. He said, I don't know what Dr. Husel's intent was. I never claimed to know what Dr. Husel's intent. And euthanasia doesn't pivot on intent. So if I intentionally am doing something to shorten your dying process, that is wrong, and it's against the law. If I intend to relieve your suffering, and that is not against the law, even if by double effect, I do shorten your life with the drug. Well, that's in a way a real contradiction, because what he's saying is, by the dosage of the medication, I can judge whether your purpose was to relieve pain or end life, and that's intent, right?
Right.
So this is tricky even when really smart people, and both of the doctors who testified are respected experts in this field.
Right.
The notion of intention and the impact or the relevance of the double effect is very real.
Right. Right. Yeah, no, and thank you for sharing that with me, David. I read that last night and was fascinated by it too. I wasn't familiar with a lot of that conversation. I can speak to it a couple ways. I looked at our policy, which was really hard one, about discontinuation of life-sustaining treatment. We actually removed it used to be called withdrawal of ventilatory support, and we're not withdrawing care. We're stopping a particular kind of treatment because that fits with the values in the moment. And the starting doses of medicines for somebody who's opioid naive, in our estimation, are similar to reasonable starting doses, which we trial for pain and shortness of breath. Opioids can ease both of those symptoms, both a kind of pain, you might say, in a simple way. And those starting doses are about 1/20th of the dose that Dr. Husel gave. However, we also note that if the patient who is being supported on life support is on continuous infusion of fentanyl or hydromorphone or morphine or whatever, we need to account for that. I'm not going to give a starting dose, an opioid naive dose, to you if you've been on a ventilator receiving 500 micrograms an hour of fentanyl, for example, because you're tolerant. And that would be a disservice, and you will suffer when I stop the medicine. So what I don't know, and I have not plumbed the record enough, is in that ICU were patients receiving high doses of continuous infusions to tolerate the ventilator. If they weren't, if this is a starting dose, I would say, if somebody shared with me that they gave 2,000 micrograms of fentanyl as a starting dose, I'd say that's outside the guardrail. That's too much of a starting dose. Start at 1/10 of that and see what the outcome is.
I traded up, right?
Yeah, and then give another dose and another dose if you need to, and document that thoroughly. My impression is that Dr. Husel, as best I can know, gave those big doses, enormous doses in some people's minds, but again, just to put it on the gradient, 10 times what might be a reasonable or 20 times a starting dose, in patients who had not developed tolerance to opioids. At least that's my guess. I don't know for sure.
And we don't know yet, and
Yeah.
we will eventually when the
Yes.
transcript becomes available.
Okay.
So that'll be a discussion
Yes.
for another day.
Right. So that's
But-
that's
yeah.
where the challenge comes in. So the dose itself cannot define intent. It has to be taken into the context of what's going on with this patient and what was going on in his mind. I can't know, but I can say that is way outside the standard starting dose for fentanyl.
And we should footnote for a discussion on another day, perhaps in a future program that you and I do, the legal versus the clinical and ethical distinction here.
Sure.
And when we talk about the ethical distinction, we're also talking about the professional ethical distinction, which is the question of standard of care and whether William Husel, as the jury concluded, had the requisite criminal intent to commit murder is a separate question from whether he departed from accepted standards of medical practice such that he was in fact guilty of what we call criminally negligent homicide. They chose not to charge criminally negligent homicide, and that was a strategic decision that the prosecutor made. Doesn't affect our ethical discussion.
Right. I appreciate that
So-
distinction. Absolutely.
So recognizing that what happened in Ohio with Dr. Husel was a function of the available proof of what his first order desired effect was, relief of suffering versus ending life, let's turn to actual sedation.
Okay.
And so that our audience is clear, can you analogize this to what happens at the dentist?
Boy, this is so far removed from any dental practice. I have a hard time with that. You've got an analogy in mind, I think, maybe. So go with it, and then maybe I can jump on board.
Well, so when you go to the dentist for just a filling, they use a local anesthesia that numbs your gum.
Okay.
If you go in for an extraction or some more involved procedure that gets into the bone, you might be put to sleep. That's something short of what we would call full-blown sedation if you go into the operating room and you're given general anesthesia. So where does conscious sedation, pardon my slip,
Okay.
where does palliative sedation fit on that scale?
Yeah. So, no, that's a great question. So this is so distinct from the Husel case in extubation. It really is. And so this is why I think talking about this is clearly very important, but I would be remiss if the audience leaves here thinking that that was badly done or maybe badly done palliative sedation when extubating a patient. That's treating catastrophic symptoms. So
right, and that's exactly the point, is
Right.
that the Husel case
Right.
is the double effect.
Yep.
It is the question of whether your
Yes.
intention was to relieve pain
Right.
with little regard for respiratory depression
Yep.
or no regard at
Yes,
all. Separate
exactly.
discussion. So we are
Great.
turning the page.
Yes. So if we move back to you in the bed, and let me put you on my palliative care unit. No harm intended here, but because that's the
Please.
place where palliative sedation, as we're describing it, usually by most definitions is going to be with very close clinical supervision, not something that typically could be done in somebody's house on home hospice, for example. And I do want to, again, it's really important to reiterate, people have been dying as long as there have been people, and most people die without medical assistance, even without needing medication to ease pain or shortness of breath. People have been doing that forever, and they do it fine, and they can do it with support in many cases in home without much of the medical stuff we're talking about. Sometimes the medical stuff with hospice help is helpful, sometimes not necessary. I'm putting you in an extreme of end of life where you have symptoms that we just cannot get control over sufficient to your wishes with conventional medicines. So going back to your diffuse bony pain, we have used anti-inflammatories and steroids, radiation therapy when you could, chemotherapy, opioids, nerve blockers, everything we can do, and you are writhing and miserable, and this is a hell that you want no more of. You have made your peace, and we have had a discussion, and I'm saying to you with sorrow, I've gone beyond what the guardrails, I've given you everything I can. You've accepted that I can give you enough opioid that it might stop your breathing, and still you are writhing. And still the dose is not ending your life. That was not my intent, but we allowed that it could, and it isn't happening because you are so tolerant to the medicines. This is a place we will have talked beforehand or with your surrogate now, that we might want to introduce a sedative into the mix. And here we're using something like a Valium-like medicine, like a Versed, midazolam, lorazepam, people are familiar with these, by vein, or propofol or a barbiturate, with the intention of making you sleepy at first and see how you are. If sleepy is okay, fine. If you need more sleepy, even to the point of being unconscious, we accept that. We allow that. We have agreed to that. And it may mean doses that render you unconscious for the duration of your life, which may come if you now stop eating and drinking, by default, sometime in the next days or week, probably.
And so let's put propofol in context, because it's a drug many people first became aware of when Michael Jackson died. Right?
Yes.
So
The meaning of medicines. Right.
So it is a drug that can induce sleep and can induce permanent sleep.
Yes.
And that's the context in which we should all understand you are taking the tools out of your toolbox.
Yes. And there are many sedatives like this. And when you talk about permanent sleep, by the way, this is with an infusion and a brief dose, which, as I understand it, Michael Jackson got to help fall asleep. I don't know if it was continued at night or what. But when we're talking about permanent, the expectation in most cases of palliative sedation is this is a one-way course, that we're not offering medicine with the expectation of lightening it at some point. There are some discussions around this that may be beyond the scope here of respite palliative sedation, brief spans of experiencing sedation to see if then on emerging people feel differently. I feel very mixed about that. There is a little bit of a literature and practice around that. But in most cases, we have come to the point where we recognize that dying time is close. We're going to do everything we can to help you stay comfortable. The only way we can help you be comfortable and not miserable is by giving sedatives to whatever extent makes sense, sometimes to the point of unconsciousness. The term that has been introduced is ordinary sedation, proportionate sedation, palliative sedation. It's all proportionate. It's all proportionate to what makes sense to you, from a little bit of sleepy to quite sleepy to unconscious, according to your wishes and according to how this unfolds.
All just a matter of degree. I take it that's what you're saying. So, these aren't different procedures. They don't involve different equipment or different medications. They're just points along a continuum.
Yes.
So when we talk about palliative sedation to unconsciousness, how do you talk to patients about the corollary issue, which is that if they are sedated to unconsciousness, they're not able to eat by mouth. And so some artificial tube feeding has to be part of the conversation. And how do you talk to patients about that?
Right. So in most cases, and I can't think of one where it was otherwise, in most cases, people who are in the setting of their medical situation, which is irrecoverable degree of suffering from a life-ending illness or illnesses, and a um, with relief or not, recognition that quality of life will never be acceptable as they had
Right.
listed it, and a reckoning that the best alternative, and for some a joyful one, and for some a very sad surrender, is to leave this life, is to die.
Right.
In which I don't have the option, as there are in some states, to give you medicine that you could take to end your life. I don't have the option in the United States of giving medicine to end your life, euthanasia, different story. I do have the option of supporting your stopping eating and drinking, supporting you through that with medication to help you feel comfortable during that if you need to or not, which gives you a, all things being equal, days to week or two on most lifespan before you die. And or if it is the pain that is moving you that we can't recover and treat with conventional medicines, sedation, so that you're sleeping through the pain, as it were.
Right.
In accepting that, that sounds better than this. Part of the deal is going to be you're not going to be eating and drinking during that. You can't. And part of this is in accepting that we are not going to attempt to prolong your life in that unconscious state until you die with food and fluid that is introduced into your stomach.
And Rob, as an ethicist and as a lawyer, this is the fascinating part of the discussion, because we have now come full circle back to the double effect.
Right.
Because you may decide to sedate someone as the only way of relieving their physical pain or their existential suffering, and yet conceptually,
yes,
if you administer food and fluid by a peg tube, and it's not food, let's be clear, it's goop, then you're going to keep them alive longer, to the extent that life is defined as pulse and respiration. So the decision by the patient that they don't want artificial nutrition and hydration, and your legal and ethical obligation to abide that decision by the patient, means that the conscious the terminal, I got ahead of myself. The palliative sedation is in fact terminal sedation. And terminal sedation is a phrase that I haven't introduced into our conversation yet, because I didn't want it to be thought of as being the same as palliative sedation. But talk to me about how you feel about those two terms.
We actually, so it's funny, I was just reviewing yesterday, we revised our palliative sedation guideline recently, and we named those different terms, and we said we are explicitly removing terminal sedation from the discussion, because that suggests that we are sedating somebody to death. And I think there's a distinction here, because ultimately the proximate cause of death in most cases like this will be dehydration, probably. And in which order of organ failure leads to that? Is it ultimately a cardiac arrest from high potassium? Hard to know for sure. But ultimately, that's the proximate cause of death. It would not transpire, probably, unless they were sedated. So that's related. But so we've removed that, because the terminal sedation can make one feel like the agent of the dying in some way, where a midwife, I suppose you'd say, to the dying. That's the title of somebody's book, probably Tim's. But not the agent in a way. And I think this is important. The challenge for me, really, David, though, is in somebody who says, no, I want to keep the foods and fluids going in Dad. He's got a peg tube. Let's just keep that going and just help him be asleep. And depending on if that's a bridge to somewhere or nowhere, if this is somebody who has more vigor and potentially months of life, this is an ethical quandary. I'm going to call my friend David Hoffman for an ethics consult about, what do I do with this? Sedate for months on my unit while feeding and keeping alive. And oh boy, I'm not going to do this alone. In fact, rarely should we do any of this alone. We really do need a team. I'm not a lone ranger on any of these discussions, but this one particularly, wow, that crosses some lines.
And that is the difficult circumstance that comes from patients and family members having, as we like to say, just enough knowledge to be dangerous. And it calls upon us to talk to that surrogate, that family member, or that designated decision maker, talk to them about what the patient's values were. Is this something that the patient would want, which seems highly unlikely? Or is this something that the surrogate, the family member or friend, is resorting to for their own psychic protection because they want to be doing everything to keep the patient comfortable, but they don't want to be doing anything that is killing the patient?
Yeah.
And that's a ripe area for bioethics mediation
Yeah,
because
right.
there's a knowledge gap there, right?
Right. So thank you for your availability in doing that. This is something none of us should be carrying alone. These are really complicated. They're heartrending. And they're complicated as well. I just should say for all those, so I'm the smarty pants chief of my service. I'm in the room, I have my discussion, and I disappear for a while, at least so it appears. My bedside nurse, my patient care tech, my environmental service person who's gotten to know this patient, they struggle with what they're seeing here. And their understanding of, what is it exactly we're doing needs to be addressed as well.
So that brings me to two, I think, really important new end-of-life standard of care questions that I want to run past you and give you a chance to sort of think about on the spot. This, by the way, is what it feels like to be in one of my classes. First, what is the obligation of a palliative care doctor to recommend to the patient or their family that they retain the services of an end-of-life doula, which is that end-of-life midwife that you described a moment ago? Is that part of what we should expect of physicians and in particular palliative care physicians?
I think sometimes yes. I think the role of end-of-life doula is a vital one, a sacred one. I think I want to offend nobody in this. I think the role of being the midwife to the dying, being at the bedside, is one that many people can provide in a beautiful way. That can be people with extensive training in this as an end-of-life doula. This can be chaplain with skill and training in this. That can be physician, clinician, bedside nurse, many others, therapist. Is there an obligation to introduce into the team, depending on what the team looks like, depending on its composition, depending on the skill, the facility, the comfort level of the team? There may be a gap in care. This is not about putting somebody asleep and letting them be in their room. This is not just about drug effect. This is about presence. This is about support for patient and family and loved ones. So to the extent any of us can offer that, end-of-life doula is one beautiful option, particularly in particular settings, home setting and others. So
And let's be clear, there's no license for being an end-of-life doula. There's lots of great training available, and I recommend it frequently. But a chaplain can fill the role of an end-of-life doula, and often that's what they ought to do when they've done everything else that they can do. So yeah. Hi, Sarah.
Hi,
yeah,
David.
time
Hi,
flew. Are
Rob.
you kidding me? How'd that happen?
Time really flew.
Always does.
So a reminder to our audience to submit their questions into the Q&A box. And thank you both for this incredible discussion. It's truly been fascinating, and I've really wanted to hear every drop of your conversation. It's truly been incredible. So thank you.
Pleasure. It's been fun. Yeah.
So one question, just to clarify for our completed life audience here who may be hearing about palliative sedation and terminal sedation for the first time.
How ought we to distinguish between squeezing the life out of squeezing the juice out of life? That is, let nature take its course. Let life continue until a disease takes over. You know, to Rob's point about a cancer tumor, really infusing the bone with a deep sense of pain, versus the theme that is pervasive within the end of life advocacy movement, and the right to die movement, which is that idea of self-determination, of being able to choose the timing and circumstances of one's death. So how ought we situate palliative and, if you will, terminal sedation within this umbrella of a continuum?
Yeah, David, you got? I've got
Yeah,
thoughts.
I want to say something from an ethical perspective, which is that the notion of letting nature take its course really falls by the wayside when we talk about a patient in an ICU, particularly one on a ventilator. So the discussion we were having a moment ago about palliative sedation and not administering artificial nutrition and hydration, that's no part of letting nature take its course. That's just management of interventions. Letting nature take its course is when you're not on a ventilator. And the issue is, do you continue to feed someone while managing their pain until their disease runs its course? The discussion that Rob and I are having is an entirely different clinical and therefore ethical circumstance, and we ought not to confuse the two.
Yeah. And I would say too, just as a quick illustration, maybe, I mean, coming to mind right now, squeezing the juice. I mean, it's an interesting thing. I had within a week, 2 patients with ALS, Lou Gehrig's disease, chronic progressive paralyzing illness. One, a young, to me, 60-something, vigorous, engaged, spiritual woman, who was relatively recently diagnosed, woke up that morning, could not move her pinky, and she said, "I will not put up with losing one more thing." And this was after some long discussion with her, with me, with family, she said, "I'm done. I miss this life. I love this life. I will not allow that to progress." And she chose, in her case, to stop eating and drinking with support in a hospice home with some sedation. That was her choice. That same week, Joe, a man who was 40-something, father of 2 kids, who was in bed, not moving, communicating with eyes, trached and vented, was able to communicate with blinks. This is good enough. I am, your words, Sarah, but I am squeezing the juice out of this life. I want my kids to jump on my lap again. Another few times. Once a week for an hour is all he had in that nursing home. He was tended to beautifully, and that was okay enough until it wasn't. And so for him, now paralyzed, unable to move on a machine, it was months after that discussion when he came to the conclusion durably that that was enough, and he was ready for medication to help him be comfortable while we turned off the vent. So this is about self-determination, and people with serious illness ought to, absolutely have the agency to make the decision when and how. Again, and I'm doing the guardrails thing. There are some legally acceptable, ethically different than legal, but related. David has a lecture on this. Guardrails we need to consider.
Yeah. And Sarah, the question points to the second standard of care question that I just want to reference, sort of footnote, because it is a whole other discussion. And that is the development in Oregon, Rob. Oregon has, as we discussed in our program on Tuesday, removed the residency requirement. And what that means is that medical aid in dying is now available, at least to those who have the financial means to get themselves to Oregon and stay there for 3 or 4 weeks. We now have a national standard and a national accessibility and really global accessibility to medical aid in dying. And what do you think that ought to do to the standard of care for clinicians, for example, in New York, in making patients and their family members aware that this is something that ought to be considered?
Yeah. Well, there is debate about this. I think from informal surveys and knowing the community well, the majority of folks who do this work, palliative care work, think in most cases when a patient has refractory suffering, when they have decided their quality of life is no longer acceptable, when they want the agency in determining how they die, when they die, where they die, to the extent they have those options, most of us are in agreement that it is our obligation to share with them what options are available and where. Not everybody does. And I should say, in my practice, one of my beloved colleagues who came through this fellowship program here, who I trained, because of his deep, in his case, Catholic faith, he has a deep belief that he cannot be the agent of helping a patient die by any means, voluntarily stopping eating and drinking. Palliative sedation, he supports, sees that as different. Medical aid in dying, no. How and when he communicates this has been the subject of some heated discussions. So within our community, there are many voices, and there may be too in CLE, where there are some differences about this. And I just think it's really important to honor that. You know, you could have a sense that all of the chorus has to agree in unanimity about the right approach here. And I think that's perilous. There are differences even within this circumscribed community to some extent. And there certainly are within palliative care. But I think in general, yes, I think our obligation is to share what's available and to help guide that.
Absolutely. And your colleague who wrestles with his Catholic faith, what he's referencing, whether he realizes it or not, is the provision in the ethical and religious directives of the Conference of Catholic Bishops of America regarding cooperation. And this is using the term cooperation not in its positive and collegial sense, but in the context of prohibited cooperation with practices that are not condoned by the Catholic Church. And that creates a very real ethical dilemma for organizations, both Catholic organizations and secular organizations that employ Catholic and other religious clinicians, about what is the extent of their obligation to either refer or at least inform. And I think the discussion about this is going to become more central clinically and ethically because of what has just recently happened in Oregon, with Oregon making itself available to anyone. And I think that's a interesting point for us to end our conversation, because I see we're out of time. But I think the message that our CLE community can take away from the discussion you and I have had is that there's lots more that we need to be thinking about, because while the ethics have not changed and the medicine has not changed, those legal guardrails have moved a little.
Fair enough.
Sarah?
And thank you, David, for that. And what you just mentioned touches upon our last question for today. Thank you, Ali, for submitting it. Do you think palliative sedation should intentionally be separated from perhaps the toolbox of end-of-life choices? So medical aid in dying, voluntarily assisted dying within the larger context of Europe, and euthanasia, given how options that include hastening death are so controversial.
Yeah.
You go first, Rob.
Yeah, and I don't know that they have to. I think they are different. They're certainly related, but they're different. Structurally, functionally, by intent, practically, in so many ways. So I think they're distinct, and I don't think palliative sedation is a I spoke in the beginning about covert ways of helping someone die. I don't think it's a covert way or a secret way or a less facile way of helping someone die in lieu of medical aid in dying. I think it's different. And I think it's appropriate. And I think people who have the option in Oregon, some people choose palliative sedation over medical aid in dying. Some people choose voluntarily stopping eating and drinking over medical aid in dying. It's not like medical aid in dying is the best way to have agency over one's death. There's something about the process of VSED that is preferable to some and allows time. There's something about this process of palliative sedation that just feels more right, makes more sense. So I think these are different tools in the toolbox. not as the poorer cousin of medical aid in dying, but as a reasonable alternative, and in some states, yes, the only option, or at least an option where medical aid in dying is not available.
And I would agree with Rob, and as someone who owns thousands and perhaps tens of thousands of tools, this has to be a tool in the toolbox. And the fact that it's different just means it's a different kind of tool. But because of the discussion Rob and I had about the connection between palliative sedation and tube feeding, and the notion that tube feeding really doesn't make a whole lot of medical sense in the context of palliative sedation for terminally ill patients, that has to be part of the CLE discussion. I won't let that go.
Well, thank you both so much. This has been a true exploration and excavation of the gradients of palliative sedation and more. So thank you. So unfortunately, time is up for today, and this concludes our 5th and final session of the 3rd annual fall conference from us at the Completed Life Initiative. Thank you all so much for tuning in. The recording will be made available next week after today's session. And if you haven't already, please feel free to check out our video archive of many discussions like this available on our website, completedlife.org. And I just want to celebrate and congratulate both of you for an excellent conversation today. It's truly been fascinating, and you answered all of my questions in discussion. So thank you. All right.
Thank you.
Thank you all. Take care. See you next time.